An adult tonsillectomy hurts, okay? It is not a fun thing. We do not like doing it, and patients don't like getting it done, right?
With that said, there's about 500,000 tonsillectomies done a year in the U.S. About half of those are adult. So they are done a lot, but you're right. They're not fun. You're down for 2 weeks. We're going to talk about what you can expect.
Welcome to Vital Discourse. This week's episode is about tonsils. Tonsils. Everyone talks about tonsils. Everyone wants to know about tonsils. What are those little things that you see on your tonsils sometimes that bother you, that pop out, those little balls? We're going to discuss that today, right? We're going to discuss tonsil infections. When does it make sense to get your tonsils out? When doesn't it make sense to get your tonsils out? What does the literature say, right? What have we found out when we've actually studied this and determined, well, should people get their tonsils out? Shouldn't they get their tonsils out? What are the pros? What are the cons? What do we do about all this? So myself and Dr. Ben are going to discuss this today. And Dr. Ben, so first of all, how you doing?
Doing great.
Doing great.
Feeling pretty happy. But as you said before, talking about tonsils it's a very quick surgery. It's a topic that gets a lot of eye rolls from a lot of ENTs because they do so many of them that they tend to become banal. They tend to become commonplace. But it is a surgical procedure, and the reasons that we do it have to be well thought out, well documented, and agreed upon by the patient and the doctor because there are consequences, right? And we're going to look at those. So why if you take a person and put them to sleep, you know that you're a lawyer now. So somebody's agreeing to be put to sleep, be put in your hands, and be cut on. So you got to have a reason, and the reason has to be good, which means that it's going to take care of the problems that are causing you to come see the doctor in the short term, and also not have detrimental consequences down the road. So they're trusting you to know that the reason they're coming in is valid and that they're going to get an excellent recovery and not have any problems in 10, 15 years. So we're going to talk about all that.
So the idea really is, when you're talking really about consent, right? So what is consent? That's a whole, legal issue for another day. But the point being is best evidence, right? So what's the best evidence to tell us? Nothing's ever absolutely written in stone in medicine. It just never is. And we all of us who practice medicine know that nothing's written in stone. We have guidelines sometimes that are put out. The literature changes constantly. Why does it change constantly? Because we get more information, right? More information might change the way we do things. So what would be considered the way to do it last year might not be the way to do it next year. Hey, don't touch that mouse. We want you to stick with us for the rest of the podcast. What are we going to learn about? We're going to learn about those disgusting tonsil balls, tonsil stones in the back of your throat. We're going to learn about what the indications are for taking tonsils out. We're going to talk a little bit about an uncomfortable thing, tonsil cancer. You're going to learn everything you need to know about tonsils or anything you ever wanted to know about tonsils. Stick with us. So with that said, what are those little things that people see in their tonsils that sometimes come out and they're really stinky?
Yeah, those are tonsil stones. And so let's talk first about what tonsils are so that we can understand why you get stones in them when they're old. I mean, what do? They're part of your lymph system, your immune system. And when you're very young, they're very important. You from the nose all the way down to anus, you have this tissue, this lymphoid-associated tissue, because this canal that starts at the mouth and goes through you is actually considered to be outside the body when you're inside that canal. It's kind of a strange thing to think about, but it's where you interact with the outside world. We take in air from the outside and we take in food and nourishment from the outside. And the body has to be careful about what you're ingesting. It has to sample it. It has to understand it. And if there's any pathogens or bad things in it, it has to be ready to react. The tonsils are part of that. So the tonsils are uniquely designed at what we call the crossroads of the aerodigestive tract. It's sitting right at the point where you breathe in and you take in food. It's at the back of the throat. In the little arches and the punching bag at the back of the throat, Right on the side, tucked into the corner, are the tonsils. It's one of those things you don't really think about until something goes wrong, until you get a tonsillitis or a stone, or it's giving you bad breath, or your throat is sore all the time, or if you're mouth breathing, you get a lot of bacteria there, chronic pharyngitis. So you don't really think about them until you're in pain from them, and then it's all you can think about. So they're sampling the world, and they are taking in little antigens and developing your immune response for later. That's only, the first couple of 2-3 years of life. After that, they play a role in it in developing your antibodies that are in your mouth and in your saliva. But they're not really considered to be integral or what's the word I'm looking for? They're not considered to be necessary. So we're going to talk a little bit about when it's time to get rid of them. But mechanically, they have crypts in them. They have these little pits in them, and they hug the food as you're swallowing, and they scrape along it, and bits of food and things go into those crypts where all the magic happens for the immune system. Well, you can imagine that it keeps doing that throughout life. And if it's getting food built up in there, sometimes bacteria, usually Actinomyces, which has sulfur in its life cycle, build up in there, and it stinks. And so if you're chronically infected, or if they have food particles in there, you get these little white stones, and you notice that your breath is bad no matter how much you brush your tongue or teeth. So that the tonsil stone is a very common reason for adults to be coming in to see if you can do anything about it. The people pushing on it and trying to squeeze them out, but they just come back.
Well, to explain it a little more simply, right, what are the lymph nodes? What's the lymph system? It's a filter, right? So anything foreign that comes into our body, the lymph system, the lymph nodes are basically our filters, right? So as Dr. Ben was saying, within the first couple of years of life, the tonsils are really the filters for the throat, the nose, what's called the upper aerodigestive tract. And you can imagine the immune system isn't really very built up in a kid, right? In a baby yet. So there's a lot of filtration going on because it's the first time the body's seeing this stuff. And when it sees this stuff, it has to react to it. And when it reacts to it, it has to create both a short-term defense against it and a long-term defense against it. And that's what these lymph nodes are doing for us. And the problem is that it's doing so much in those first couple of years that the filter gets kind of clogged. And when it gets clogged with bacteria, what happens? The filter itself gets infected. The tonsil itself can get infected. Now, from the perspective of the stones, as Dr. Ben was saying, the stone part of the issue is there are little crypts, little cavities in the tonsil. And so food and debris get caught in there and you get these little stones. So let's go back a little bit. How do we treat that? I mean, you have someone coming into the office saying, I'm getting these stones, they stink. It's not that my tonsils hurt or my throat hurts, but these things stink. Ben, what do we do? What do we do?
So people have tried a lot of things. People have tried squeezing them out. People have tried doing antibiotic regimens, rinses, gargling. The only real permanent way of getting rid of them is to remove the tonsil. And a lot of people have tried very non-aggressive, non-surgical ways to get rid of it, tinkering with different amounts of or different substances that they're going to gargle with. But nothing's really been shown to depopulate those crypts. First of all, mechanically, they're going to keep doing their job, and they're going to keep collecting food in them, and the bacteria is going to keep building up. Actinomyces is a pretty tough character, and it doesn't respond. You can't really get high levels of antibiotic into those crypts. You can get it into your bloodstream, but not into the crypts. So removal, either subcapsular or complete, is pretty much the only way to permanently get rid of those crypts and the stones that come with them.
So what do you do in your practice when someone comes in with tonsil stones?
If I see the stones in there, I talk to them about it, and I tell them what I just told you. It's, we can try to tinker with it. Most of these people have already been through their family practice doc, maybe some urgent care, maybe chatting with internal medicine folks, either friends, family, or their personal physician. And so they've already tried a round of antibiotics, maybe multiple rounds of antibiotics over a year. I also talked to them about nasal breathing because quite often what sets up chronic inflammation and chronic infection in the tonsils is aberrant breathing. If you're mouth breathing at night, there's a very high risk of changing the population of bacteria in your throat and allowing actinomyces to build up on the tonsils. It causes the whole lingual tonsil and palatine tonsil to swell, change the bacterial flora from facultative anaerobes to more aerobic respiration because you have oxygen. Your mouth is supposed to be closed, but if it's open all the time, different bacteria build up. So I ask them if they're nasal breathing or mouth breathing, if they wake up with dry mouth. If there's something that I can correct, I correct it. So if I can change their nasal breathing and make it better and they keep their mouth closed, we'll wait a month or two before I talk about removing it. But I tell people I'm going to probably wind up taking these out. If you've already tried a couple rounds of antibiotics and some gargling and rinsing, it's probably not going to get much better than that. So let's remove the tonsils.
So essentially, you're telling me that someone's tonsil stones can be caused by their lack of nasal breathing.
Yeah, that's right.
That's pretty incredible, right? I mean, that's certainly not something that someone would think of when they see all of a sudden I have tonsil stones. Oh my goodness, this is coming from my nose. But yeah, it actually can be. I can tell you in my practice, what I usually do, I'll put them on someone on a more extended course of antibiotic therapy because I find a lot of times when they've been treated before by urgent cares, primary care physicians, that type of thing, I see a lot of 5-day and 7-day courses of antibiotics.
5-day, 7-day, 10-day.
Yeah, and the thing is that's not really going to build up enough concentration of antibiotic in the tonsils. It's just not going to happen. So I'll put them on a 3-week course of antibiotics, see if I can sterilize the tonsils and see if that makes any kind of long-term difference. I'll also have them use a water pick, right, the old-fashioned water pick, and after they eat, water pick their tonsils. Bit of a pain in the butt, right, to do so, but you know, if you're looking at the difference between taking your tonsils out and doing that, an adult tonsillectomy hurts, okay? It is not a fun thing. We do not like doing it, and patients don't like getting it done, right?
With that said, there's about 500,000 tonsillectomies done a year in the U.S. About half of those are adult. So they are done a lot, but you're right. They're not fun. You're down for 2 weeks. We're going to talk about what you can expect.
And we'll talk about the indications for tonsillectomy a little bit different in kids than in adults. But we'll go into that shortly. The other thing that I will offer them short of removing the tonsils completely is doing what I call a tonsillar ablation. So what I'll do is I'll actually cauterize the surface layer of the tonsil down to the depth of the tonsillar crypts. It's nowhere near, it's not a true subcapsular tonsillectomy because I'm not removing tonsil tissue, but just cauterizing down to the level of the tonsillar crypts. If you think about it, you know, a tonsillar crypt might look like that, right? That's the cavity that everything's getting caught in. And if I can take a crypt like that and make it really short like this, it's much less likely that things are going to get caught in. And I've had pretty good success doing that.
How do you do that? Do you do that with a microdebrider, or do you do that with a laser, or how do you do it?
I actually do it with a needle tip electrocautery. That's what I found works the best.
Got it.
For me, that works. So that's tonsillar stones. Everyone knows. That's all they need to know about tonsillar stones. Let's go on to tonsillitis. Tonsillitis, infection. Anytime you hear itis in anything that we talk about, itis means inflammation, right? So that inflammation can be caused by infection, probably the most common way, or it could be caused by something else. So in this case, when we're talking about tonsillitis, we're talking about infection. We separate that into pediatric, little kids, and adult. So let's first talk about pediatric tonsillitis because that's a big thing. As Dr. Ben was saying, that the numbers in terms of tonsillectomies, which dwarf the numbers that we used to see in terms of tonsillectomy, because of the criteria Dr. Ben is going to talk about, really have diminished, but still quite a number of tonsillectomies that are done. So, Dr. Ben, talk about the criteria for tonsillectomy in kids and how it came about.
Yeah, I mean, the criteria for it is called the Paradise criteria. It came from a very large set of studies that were done and then analyzed in a meta-analysis But in general, you see an evolution
Dr.
of
Ben,
this.
if I could interrupt, what's a meta-analysis?
So a meta-analysis is when you have a whole bunch of studies that are done. They have some equivocal findings. You take all of them, pool them together, and try to figure out how they all go together so you can compare apples and apples through all of that data. So you pool all the data together and try to get an answer one way or another on data that looks a little bit disparate from the surface.
So it's what we call a retrospective study. We're looking backwards as opposed to looking forwards.
You look back at all the studies that were done. You try to make some sense of them by pooling their data when it's possible. So there are criteria that you need to follow for that. But in general, if you follow the decades, back in the 50s and 60s, almost everybody got their tonsils out. In the 70s and 80s, people got worried about it. Hey, is it affecting the immune system? And so it declined rapidly and to a very low number. And then we started to realize that with these larger studies, there really isn't any sort of diminished capacity for developing an immune system by removing the tonsils. And so the current position of the American Academy of Otolaryngology is that it doesn't cause any long-term effects in any of the blood-borne, what we call humoral immunity. And so your B cells put out antibodies, and that's what wanders around the body and helps us to attack and defend against bacteria and viruses. And there really isn't a diminishment in that, with an asterisk. There is a very large study that showed that there is about a 17% increase in infections if you follow it out for 30 years. So there is we're going to talk a little bit about that. There's nuance to all of this. We don't want to get lost in the weeds. We want to give a solid message, but there is nuance, and you can't overlook a study that has 1.2 million people in it followed for 30 years. That's a pretty powerful data set, and you have to look at it. So in general, American Academy of Otolaryngology, which Dr. Lee and I follow, they say, look, this is very safe to do, and there's reasons for it. And they set those reasons out based on a meta-analysis. That's the Paradise criteria. If you're having, in the short term, if you're having more than 7 documented infections in an individual, in a little child or in an adolescent or adult, more than 7 in a year.
7 or more, right? 7 or more?
Yeah, it's more than 7 or more in a year, sorry, yeah. Or if you're having 5 or more per year for 2 years, 3 per year for 3 years, then it's probably an indication to get these things out, because and you can also supplement that with significant lost work and school time. So if you're constantly missing school, constantly missing work because of these infections, you can play with those numbers a little bit. Dr. Lee, do you know what do you know how often people follow that criteria, though, doctors? How often do doctors actually tabulate 7 in a year, 5 a year for 2 years, 3 a year for 3 years?
Well, that's very difficult, because the question is how are you going to document this? Are you going to document it because a parent comes in and says, yeah, he's had 7 infections this year, or, okay, so how many did he have in the last 2 years? And I apologize for using he or she. How many in the past 2 years? Oh, it's a lot. It's just a lot. Okay, is it more than 3? Is it more than 5? Is it more than 7? That history can be somewhat suspect. So then you say, okay, well, let's figure out what the pediatrician says. Get the pediatrician's records. Get the pediatrician's records, and it says this number. And then you go back to mom or dad, and they say, well, those weren't the only times, because we went to urgent care a couple of times as well. Or there were a couple of infections that we actually didn't treat, but it got better by itself. So it can be very messy in terms of determining these numbers.
Having a scribe in the room with me is great, because she's always locked in. And while they're talking to me, she logs on to their pharmacy. So it really I have real-time backup as to what they're saying is true. Oh yeah, no, I had 4 rounds of antibiotics in the last 3 months. Meanwhile, we look at it, and the last round was a year and a half ago, and it's only 1 round. So people's recollection and what they say to you, if you can immediately substantiate or negate it, it's really helpful to you as a clinician to start to understand how valid is this. And just so you know, in tonsillectomies, only about 15 to 30% of doctors follow this criteria. Typically what's happening, it's the school or work piece. So it's like, look, the parents coming in, if they're coming into my office, I know there's a problem. They didn't take the time off work and take time out of school to come in to talk about nothing because there's no problem. They're coming in because, they have an issue that they need to solve. And it's the short-term issue that starts to evolve in their mind what needs to be done. So if I'm missing a bunch of school, I have intense pain in my throat, and it never seems to go away, I want the problem solved. And if they've already gone through their doctor or urgent care, you're the guy that needs to solve it. So you got to come up with something. What they don't want to hear is that, let's wait for another year and see how bad this really is. That is probably something that's like, inside a riot in the waiting room, because you've usually been through quite a bit before you get to the specialist. Isn't that right?
Yeah, and really what you're doing is you're taking some of the adult criteria and you're overlapping it with the pediatric criteria. So the pediatric criteria is very specific in terms of the number of infections. And realize that's not the only thing. There are other reasons that you might decide to take tonsils out. Something called the peritonsillar abscess, which is a very severe infection that occurs right around the tonsil in people that have an otherwise acute tonsil infection, obstructive sleep apnea in children. So there are other reasons to take tonsils out other than the recurrent infection that we're talking about. But in the adult criteria, for example, the Natina trial, which kind of governs how we treat the adults, is more time off from work. How is it affecting activities of daily living, time off from work, that type of thing. We treat adults a little bit differently than we treat the children in terms of those criteria.
Well, no, the kids are treated the same because it's also time off school. It's hard to tell. We say 18 and you're an adult, but we also talk about adolescence, and you can tell when you take somebody's tonsils out in a child, it doesn't hurt that much. They recover very quickly in a young child. In an adolescent, they behave more like an adult, and quite often it's hard to tell whether they're going to bounce back real quick or if they're going to be in pain for 2 weeks. And so a lot of the criteria, I think why we don't follow the Paradise criteria only 15 to 30% of the time is because you start to talk to them about the effect on them. You're not going to wait a year to see if there's 7 or 3 years. These people want answers, and they're missing school. So we treat school like work. And a lot of docs probably insert that instead of just going strictly off the Paradise criteria. They sort of say, well, they're missing a lot of school at a critical time, and it could affect their downstream education, getting into a right college or something. And so, they side with the parents and wind up taking the tonsils out.
Which is the point I was trying to make, is that there is an overlap between how we treat the adults and how we treat the kids. Right. One might be work, the other might be school, but it's the same idea, generally speaking. So let's look at what we can expect when tonsils are removed. So what can we expect? We're getting a lot of infections after the tonsils are removed. Well, we're not getting tonsil infections. But does that mean that we're not getting any type of throat infections? There's no more strep, there's no more throat infections for the remainder of that person's life? How long does it help for? What exactly does it do?
Usually it helps in the first 2 years. You get a noticeable drop in the number and severity of infections. Not gone. We don't suddenly miraculously make illness a thing of the past. But the number and severity of infections noticeably drops off, and that effect is mostly documented in the first 2 years, most in the first year, but also in the first 2 years. So to your point, it doesn't mean that for the rest of your life you're never going to have a problem. You have that lymphoid tissue all around the inside of your throat, what we call Waldeyer's ring. You might have heard of that. You might see it if you Google this stuff. And part of the adenoids is part of it, the lingual tonsil, the whole back of the tongue, that bumpy stuff that you start to see at the back of the tongue signals where you go down and have a tonsil all the way across the back of your tongue. That doesn't get removed. And so you can still get the same types of infections. It won't be tonsillitis necessarily, but it would be pharyngitis. Like Lee said, the itis tells you that we're talking about inflammation or infection.
So would you say that a physician would be wrong if they told a parent, look, I don't really think that there's an indication to take the tonsils out based on the fact that there's only going to be an improvement in infection rate for 2 years, and the morbidity or the risk outweighs the long-term benefit? Would you have a problem with that?
In my practice, I would, but I wouldn't have a problem with that. That doctor's not wrong. I think that, we were supposed to be facilitators and educators. We're supposed to guide folks who are coming in looking for answers. We're supposed to guide them through the medical literature, what we know to be true. And I would say, I would pose it to you. Would you say if a patient came in, be it an adolescent, a child, or an adult, and they had been doing reading and decided, yeah, my mom's bringing me in, or my husband wants these out, but I've been reading and I don't think it's a good idea to risk tonsillectomy, given the fact that it doesn't help that much. Would you try to argue against them? That's an interesting way to look at it. What would you do there?
I try to never argue a point one way or the other. From my perspective, I feel as a physician that my job is to give them information. If we're dealing with something like cancer, for example, where there's a real life issue that we're dealing with, then my opinion, I think, is very, very important. I think in something like this, where there is literature on both sides of this coin, because there's a subsequent study to the Paradise study that actually said that the risks do outweigh the benefits. There's a 7.9% complication rate with tonsillectomy. And if you look at patients that continue to have their tonsils in, it was only about a 0.16 to 0.43 episode per year infection rate if the tonsils were kept in, even in those kids that were pretty serious in terms of their number of tonsil infections. So my job at that point, I think, is to tell them, there's literature on this side, there's literature on this side. I can't make that decision for you. That's not my child, but you deserve to have all of this information, and I have no problem following either one. I understand the argument on both sides. What you want me to do is what I'm going to do in this case, and we'll deal with it.
So Lee, I'm hearing a little bit of a crossover here with law and medicine. In this instance, it's a little unique, right? Because you could argue it from both sides. You could argue and have evidence that says having a tonsillectomy might be, a little bit more risky, painful, difficult to go through than the benefit I'm going to get from it. Or you could say, I'm having such a difficult time with this. The risk is fairly low compared to other things, and so I'm gonna choose to take it out. You could argue both of those sides and support it with literature.
Well, look, one of the things that I learned in law school is not to be necessarily completely dogmatic about anything. And the reason is because, number one, you don't know everything. There's always information or evidence out there that you might not know yet. And so you have to research it. And that means even researching what's truly going on with that patient, with that child, with that adult, because sometimes you're not getting all the information. And I think as physicians, we're kind of taught to be dogmatic. We're taught to take a side, that there's a right way and a wrong way for just about everything. And I don't necessarily think that's the best way to practice medicine. I think that we really do have to look at both sides of every coin and understand that there are arguments to be made on either side, and no one is necessarily right or wrong.
That's a great point. I knew you would be able to kind of succinctly state that. But as I was going through this, and as I've gone through my 30 years in medicine, 20 as a practitioner, you do start to realize that you don't know everything. The patient has a very important role to play in deciding what you do, and the outcome has to fit what you're trying to accomplish with them. So all those three things start to mellow as you get older, and you see a lot more in your practice. You're not so dogmatic. You realize that there is variation. Patients' bodies don't read the textbooks. I'm sure you've seen it too. I've seen some really very strange anatomical differences, physiologic differences, and you don't ever want to convince somebody that a surgery is right for them. You want to come to the conclusion with them through education that this is the right pathway for them to take.
I'll give everyone a great example of kind of what I'm talking about. So I remember when I was a resident, and we had a facial plastic and reconstructive surgery course at Mount Sinai, New York, every year, run by Bill Lawson. And we had visiting surgeons from all over the world that were considered the absolute best of the best in doing cosmetic surgery of the nose, doing rhinoplasty. And we did live cases, right? So there was a plastic surgeon from Beverly Hills, Frank Kamer. The guy was amazing.
I know Frank.
Yeah, he presented this patient, and the patient had kind of this defect in the tip of the nose. And the first thing that was asked was, all of these visiting surgeons on the panel, how would you address this? How would you address this? How would you address this? First of all, everyone had a different way of addressing it. Okay, some people were going to do a complete reconstruction, take cartilage from here, from there, flaps, whatever it might be. Some people a little bit less. And so Frank Kamer said, "Okay, I'm going to show you what I'm going to do." He made a little pocket right over the area where the defect was. He took some cartilage from the septum. He crushed it. He put it in the pocket. Put a couple of sutures. The tip looked perfect. I mean, perfect. So here you go. You have people being very dogmatic. This is the only way to fix this. That's the only way to fix it. And look, he takes 5 minutes, did something that no one else would have ever considered, and the tip looked perfect. So you've got to understand that there really is not necessarily ever an absolute right or wrong, even in medicine.
People's bodies don't read textbooks. Everybody's different, and the way that you go through your career, we all have that one point, that crossroad, med school that we go through, and then residency. But after that, it's all based on experience and variation, and the doctor that you are 20 years after your training is very different than the doctor you were 1 year after your training, and so the rest is all where the variation lives.
Yeah, how many times have you seen a patient, second opinion, and they went to a young surgeon before they came to you? And you say, well, okay, you went to Dr. So-and-so, what did he say to do? And he says to do this massive procedure. We've got to do this, and we've got to do that, and we've got to do this. And the first thing you do is just shake your head, right?
Actually, I was just humbled. I don't know if this will make it into the episode or not, but I was just humbled by something very similar to what you just said. A patient came in, and they had dumped on my practice. You probably had this happen as a facial plastic surgeon. They had done a massive removal to the tip of their nose for melanoma. I mean, a massive portion of it removed, including a tiny little break in the lining of the nose. So it was through and through with cartilage gone. And I told the guy, well, I'm going to have to do a forehead flap. I'm going to take some cartilage. I'm going to rearrange the flaps inside, and it's going to be a big deal. And, there's going to be multiple surgeries. And it's going to take about a couple of months to finish everything, but it'll look pretty good at the end. And the guy said, yeah, I'm not doing that. I paid for a big trip to Europe, and it's like $30,000, and I leave next week, and I'm not changing it. And and to your point before, well, this is cancer. I was like, I really think that's a bad idea. I think you should put this off if you can. And he's like, I understand what you're saying. I'm not doing that. And he went away. He came back about 4 months later. His nose didn't look that bad. Yeah, it was a little. The nostrils were a little different, and it kind of it pinched up a little bit, and he clearly had some nasal valve collapse on that side. But he's like, I'm breathing okay. He had no snoring issues or anything. And you look at his nose, and you could tell that something happened. It's kind of swirls of large scar there. But I got to be honest, it wasn't that bad actually, and so. It was very humbling. Wow. I'm glad that he came back in to show me. So we had a very good rapport.
And we'll get this. We'll do a whole episode on rhinoplasty and nasal reconstruction and that kind of thing. And I think everyone will really be excited to hear about that stuff. But let's move on a little bit on tonsils. Another indication in pediatric patients for tonsillectomy is obstructive sleep apnea. Can you go over that a little bit?
Yeah. So. The focus of this is more adult tonsillectomy, but in adults we don't really think of the tonsils, taking the tonsils out, as having much of an effect on sleep apnea per se, unless they're massively enlarged and touching in the midline, what we call kissing tonsils. And then it can have a little bit of an effect on it, certainly on your ability to wear the mask and whatnot. It's part of the removal of some of the tissue at the back of the throat that people know as a UPPP, a uvulopalato-pharyngoplasty. And that can have a little bit of an effect on, although it's not the tonsillar tissue per se, that when you do remove the tonsils with it, it has a slightly higher success rate in terms of lowering the AHI. And the AHI, of course, we know is the number you get from the sleep. How severe is your sleep apnea? In children, it's a little different. I mean, a lot of the obstruction that we notice in children with sleep disordered breathing, snoring in children, mouth breathing in children, comes from the adenoid and tonsillar tissue that's hypertrophied, that's bigger. When we say hypertrophy, we mean that it's enlarged. So the enlarged tissue at the back of the throat, the tonsils, and removing it can have an immediate effect. And so one of the first things that we do if somebody comes in for snoring in a child with enlarged tonsils is we remove the tonsils and see how they do.
Yeah, and so that was actually shown in the CHAT trial, the child adenotonsillectomy trial, which showed that removal of tonsils and adenoids in pediatric patients with obstructive sleep apnea showed a really, really significant improvement in AHI, or the number of obstructions they had per night. So in kids, to your point, that's a really big deal. Taking those tonsils out in a child with obstructive sleep apnea is a very important indication.
So if children are not breathing well at night, we know that they do poorly in school. There's a noticeable detriment for getting lower grades and more days missed. And when you remove the tonsils and fix that sleep disordered breathing at night, that goes away. So I think we should talk a little bit about what to expect when you have the tonsillectomy versus a child versus an adult, because there's a lot of misinformation about it. How do you talk to patients? Do you tell them, do you sugarcoat it? Do you tell them it's going to hurt? What's your spiel when you talk to a patient about a tonsillectomy, child versus an adult?
So pediatric tonsillectomy, and in full disclosure, I really don't do pediatrics anymore in terms of tonsillectomies. But when I did do peds, the kids, they really bounced back so easily. And so, yeah, first week it's going to be very significant pain. Child's not going to eat very well. Hydration is the most important thing for that first week. If you have a very low weight child, that becomes a bit of an issue, right? Certainly you want to keep the hydration up, but you have a low weight child, you certainly don't want to drop the weight too much more below that. There's the risk in kids when you're dealing with bleeding after tonsillectomy, which is the big major complication that you can get. If a child has a very significant bleed, that could be life-threatening. When an adult has a very significant bleed, not quite as much, right? So parents have to understand that type of complication and the rate that it can happen. And you could do everything absolutely 100% right, and afterwards a child could cough and there you go. All of a sudden, there's a significant bleed. So parents need to know that. They need to know that that's a complication. They need to know that their child is going to not feel great for that certainly that first week. Second week will be much better. But kids tend to bounce back much, much quicker than adults. When I speak to my adults with tonsillectomy, I tell them, it is really going to be a terrible first week. I'm not going to lie to you, okay? You need to know that. Now, usually I'm doing tonsillectomies in adults for obstructive sleep apnea, and they're like, look, I don't care. I just don't want to use that CPAP machine. So, they're okay with it, and they can make that choice themselves. But that's pretty much how I go over it with them. Obviously, there are different ways of doing tonsillectomies. You can do a complete tonsillectomy where you're actually taking the tonsil off of the muscle. So you're leaving raw muscle. That's a lot more painful than doing something called the subcapsular tonsillectomy, where you're leaving the capsule of the tonsil on the muscle, so you're not getting raw muscle. Hurts a lot less. And then there are other different tools that you can use. So some people will use what's called electrocautery. Other people will use radio frequency. Other people will use laser. Other people will use thermal energy. Some people will use coblation. So there are a lot of different ways that you can do it. There are studies on almost every one of these, right?
If the subcapsular dissection is a lot less painful, why don't all doctors do it? What are we trying to avoid? Why wouldn't we all just do subcapsular?
So I think there are two things. Number one is why you're doing the tonsillectomy. If you're doing the tonsillectomy because the tonsils are just big, for example, for obstructive sleep apnea, no reason that I can think of that you wouldn't do a subcapsular tonsillectomy. If you're doing it for chronic and recurrent infection, then theoretically, if you leave some of the tonsil down, then that tonsil could continue to get infected. Certainly not as much as a bigger tonsil, but theoretically could. The next thing is if you're doing it for asymmetry of tonsils. So we'll talk about that in a second when we talk about tonsil cancer. But if you're taking a tonsil out because one tonsil is a lot bigger than the other, and you think, well, I want to take this tonsil out because there could be lymphoma or carcinoma in that tonsil, then certainly in that case, you want to get that entire tonsil out. So that's, to my way of thinking, that would be the difference. Subcapsular tonsillectomy also takes a little bit more finesse in terms of getting a tonsil out and not getting down through that capsule. So you really kind of have to know where you are.
Awesome. So what we know then is that for adults specifically, the surgical removal can be subcapsular or can remove the entire capsule. In general, you're going to be in pain for about 2 weeks. Recovery is not like a child. Child bounces back really quickly. Let me ask you a question. Pain management. What do you do? Have there been great advances in the last 30 years on how you manage the pain afterwards? And does the whole 2 weeks have to be a nightmare, or can people expect to get through that 2-week period of pain a little bit better now than before?
So there are different ways of managing the pain. To me, the most important way of managing the pain is hydration. A dehydrated patient is going to be a miserable patient almost every single time, no matter what else you do. So that's the biggest thing. And not just hydration with water, hydration with electrolytes as well, because they lose their electrolyte balance. And that can cause secondary dehydration when there's an imbalance in your electrolytes. So adding electrolytes to fluids or using fluids that already have an electrolyte profile, I think is very, very important. We really can't prescribe the same level of narcotic that we used to, especially depending on your state, right? So usually 3 days is the maximum amount of narcotic that you can prescribe after surgery these days in most states.
Texas is not that way.
I'm sorry. Well, in Florida it is. Florida 3-day maximum.
I know. But do you give other pain meds? Are you using other of some of the more advanced pain meds like Celebrex or Susitrigine or tetracaine lollipops to augment the use of narcotics? Yeah,
so we'll use Toradol, which is non-narcotic. We will use lidocaine gel. Basically, they have them gargle with lidocaine gel. afterwards. That really helps significantly. There's always the risk, the theoretic risk, that if you use NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, that type of thing, that you can increase the risk of bleeding. From my perspective, after 48 hours, I allow people to go on NSAIDs.
You don't put them on Celebrex?
I will put them on Celebrex. Celebrex has a lower. We actually use Celebrex pre-op as well.
So do we. We do it for 3 days pre-op and then 10 to 15 days.
Yeah, and Celebrex, although it's an NSAID, has a lower potential to cause bleeding.
And we use what dose do you use? We use a pretty high dose.
400 milligrams.
Yeah.
Yeah. Is that what you use?
Yeah. And so do you also use Susitrigine?
I have not.
Susitrigine is remarkable. I think it might change your practice. It's a great standalone, but it's the first new pain med in 70 years. It's a new category. It's an N35 sodium channel blocker. So the N35 is only in the P fibers. So it actually stops nerve conduction in P fibers. And so their ability to experience pain is drastically diminished without changing the way you breathe, without, what we're afraid of with narcotics, obviously, is that, you have this swollen, obstructed airway, and then we suppress your breathing. Well, that could be dangerous, at least in our mind. And so we try to decrease the amount that we need. Also, a lot of times it doesn't really get rid of the pain. It makes you not care about it as much, but it doesn't really stop the pain per se. And so I layer it. I give Celebrex for 3 days before and all the way through the 2 weeks. And then I give a tetracaine lollipop that you can suck on for a few minutes, 5 to 10 minutes. And it gets you to be able to drink a little bit better. But then I give Susitrigine. And the patients rarely have to use the narcotics.
How has insurance coverage been with that?
It depends. It's expensive right now, like Celebrex was many years ago. I couldn't give Celebrex before because insurance didn't want to pay for it. And the patients found it to be a bit high. Susitrigine right now is a little bit expensive. For tonsillectomy, they've been paying for it. The insurance has been paying for it. For my nasal procedures, they haven't been, but I always tell folks about it if they think that they're going to be kind of owie after a nasal procedure. I tell them if they want to get that extra little oomph. But it is miraculous.
And this, actually, I think this is a good time to talk a little bit about a guest we're going to have on in the future. Dutch Rojas is going to go over what's going on in our healthcare in the United States. And I think that's going to be a great question to pose to him. Okay, here we have a great new medication. We can't get insurance to pay for it. Okay, what the heck is going on? Right?
Yeah.
And so Dutch will really be able to give us some good insight as to why that type of thing happens
and what effect this new Trump RX is going to have on things, because it's supposed to drastically reduce the cost of all medicine. So we'll see. Yeah,
we'll see. Exactly. We've heard promises for years about a lot of different things. Right. So we'll see if this one comes to fruition.
Let's kind of talk about the complications a little bit here. A lot of people bring up complications and they're afraid of them, and they're afraid of the bleeding. So we mentioned before, 500,000 tonsillectomies done in the U.S. each year, about 5 million worldwide. So it's probably one of the most common surgeries done. And things happen, and there are complications. What are the most common complications?
Oh, bleeding, right? That bleeding is the number one. The number one that we worry about.
Well, is it the most common or the most feared?
Well, it's certainly the most feared, not the most common. Okay, and look, it depends on what you call a complication as well, right? To me, dehydration is
yeah,
right. Especially in pediatrics, that's a complication because they end up in the hospital for it, right? Just for dehydration and nothing else. So, dehydration, malnourishment, that type of thing, certainly. Infection is a very, very uncommon thing after tonsillectomy. You would think, that, especially in that area, infection would be important, which brings up another question. Do you put your kids on antibiotics after tonsillectomy?
I do. The children, mostly because if you decrease the bacterial load in the throat, quite often you have a little bit of a resolution of pain. It's not required for an infection. Most of the studies show that it doesn't really do anything. The infection rate's so low that the number of patients you'd have to have in that study to pick up a difference, the power is, all those studies are underpowered, but none of them show any sort of infection rate. So I think a lot of times it's a little bit of voodoo.
Completely agree on that one.
But I still do it for adolescents. So
yeah, completely agree. It's likely voodoo, but it makes us feel better, right? It makes us feel that our patient is covered. And look, in the end, we worry about our patients, right? We all do. Anyone that thinks that a doctor, that a dozen surgeon isn't worrying 24 hours a day,
you're
about
thinking
their
of it all the
patients
time,
is utterly wrong. That's all we think about. It permeates everything in our lives, right?
We said before that bleeding's the most feared complication. In a way, yes. Obviously, death. There's 500,000 of these done each year. There are some deaths each year from this, and patients bring it up. I think, it's something that in the consent you have to talk about. About half of those deaths, I think it's 17 per 100,000, something like that is the current rate that they throw out there. So, or I know it's 7. I think it's 7 per 100,000, but it's fairly rare. It's very rare. But if you do it long enough, it's bound to happen. And quite often, it's an anesthesia complication. Or from bleeding, so post-obstructive pulmonary edema, things like that. And the bleeding part is usually a combination of factors that keep popping up in each one of these cases. We had one in my residency. It's when a person is not really giving the bleeding the credence that it deserves. In other words, there's some bleeding. They live outside of town. They're far away from getting help. Maybe there's some miscommunication as to when, should I head to a hospital right now or shouldn't I? Those things seem to be a common thing. Also, kids that have developmental problems, developmental delay that can't necessarily, or they're too young, they can't necessarily tell you what's going on, and they're swallowing the blood and you don't see it. Those are common themes that seem to come up. So this is a very rare complication. It's obviously devastating for the doctor and the family when it does happen, but it's not something that should prevent you from getting it done if you have indications to do it. It's usually some extraneous circumstances that confound or compound the problem. Is that what you find, Lee?
Well, yeah, you bring up the issue of the sentinel bleed, which is the reason that things will potentially get missed. And that is, before a major bleed, there's usually something called the sentinel bleed, which is a smaller bleed where the blood vessel opens and closes. So there's some bleeding, and then the bleeding stops. That's the sentinel bleed, right? And if that's not evaluated, if we don't bring the child to the emergency room and evaluate that sentinel bleed, we might miss what ends up being the major rupture subsequent to that. So to your point, sometimes these things are missed because the sentinel bleed is blown off, so to speak. I shouldn't say blown off. It's not recognized as being as important as it is in terms of requiring an evaluation by the surgeon.
Most people quote the incidence of bleeding after tonsillectomy about 1 in 100. It can be a little bit higher in adults, can be a little bit higher in someone's practice.
And that is something significant. I mean, it really is. So when you say, well, don't let this keep you from having a tonsillectomy, well, frankly, I wouldn't say that. Okay? I would say it's up to you. What is your, how risk averse are you? If a parent said to me, I am unwilling to allow my child to have a tonsillectomy because there is this small percentage chance that there could be significant bleeding and or death, I would say, you know what? That is your decision, and I completely respect it.
And I often do say that to people. I don't ever go against them. I wouldn't let it stop me from getting a tonsillectomy. That doesn't mean that I would tell my patient to get it. If a patient comes in and says, look, the risk of death is too high in this for me, that's their threshold. Absolutely. My job is to tell them what the rate is, not to tell them whether or not that's too high a risk.
Wow. You're sounding a little like an attorney there, Ben.
Right. I know you keep pushing me to take the LSAT and do or do law school, but I don't know. Watching you go through it was torture.
Okay, let's talk about tonsil cancer.
Ooh, yeah, the cancer portion is always tough because the big C word scares the hell out of everybody, and rightfully so. We are doing a lot better with cancer now than we were, 40 years ago. When I was in med school, they announced to me that I'm one of the first classes to ever get a discussion on the actual mechanism of cancer, and we happen to know how it's caused now. And all of our professors were sort of saying when I was in med school, they weren't sure. They didn't know if it was, an illness, a virus, a bacteria. They didn't know what it was, what was causing it. So they were very proud to be telling us that we know what the mechanism is. Now we just got to grind and do the work to figure out each cell type. So cancer doesn't have a lot of the survivability on a lot of these cancers is increasing, but it's still very terrifying. And tonsillar cancer is part of the head and neck spectrum. Most of them are squamous cell carcinoma, and some of them are caught early, some of them are caught late because you look at the tonsil, it's kind of hard to see whether or not something's growing in there until the entire tonsil starts to expand, or you see a neck mass. Quite often you'll get a neck mass before you can see the actual primary in the tonsillar adenoid. But either way, the treatment has gotten a lot better over the past even 25 years. So the outcomes are getting into the range where with chemoradiation, it's up in the 80-90% range if you catch it early.
Well, that said, should I get my tonsils out so I don't get tonsil cancer?
Again, it depends on what your tolerance is for the risk, right? I mean, the risk is fairly small. If you are a smoker drinker, and or that you've been HPV exposed, and you don't want to tolerate any risk at all, you may want to. But again, you can get tonsillar cancer in any of the tonsil tissue inside the head, so it's not going to completely alleviate that risk. But all I can do is tell you that. I can't tell you that it's the wrong thing to do. It certainly would in a minuscule way reduce the risk of getting cancer in those tonsils, in the palatine tonsils, but it's not going to take away your lifetime risk.
If I'm someone that has chronic tonsillitis or recurrent tonsillitis, is my risk higher to develop tonsil cancer?
It is. Yeah, we were talking about that the other day. It's there is a small but significant higher risk in people that have chronic tonsillitis.
And why is that? Is it the bacteria? Is it the infection that causes the increase? Chronic
presence of inflammation is a hotbed for mutation and for cancer. I mean, cancer is and we're going to do a whole episode on cancer itself, because it's not just head and neck cancer. Cancer itself, the things that are changing in the treatment of cancer, the detection of cancer, are miraculous. So it's a little bit beyond the scope of this, but I mean, cancer comes from mutations in the way cells regulate themselves, cells behave. The cellular machinery changes, and the cell stops obeying the rules that make it a good partner inside the body, and it starts to do things and to grow outside of its norm. So when you have a lot of inflammation in an area, it's a hotbed for change to that cellular mechanism. So chronic tonsillitis, chronically imbibing things, chronically drinking things that are toxic to the body, lower the defenses, sure.
Yeah, and research shows that combination of chronic inflammation plus the HPV infection, it has a booster effect, right, to increase the risk even more of tonsil cancer.
Yeah, depending on where that HPV integrated into the genome, it could integrate right next to a tumor suppressor and knock it out, and all of a sudden you have cancer.
So does this mean that we could potentially almost completely obliterate head and neck cancer, at least HPV-related head and neck cancer, if every child got Gardasil?
No,
Why not?
no. Because they're not all caused by HPV. There's a lot of cancers, a lot of head and neck cancer that has nothing to do with HPV. And in fact, the HPV cancers that we do that are documented from HPV respond a heck of a lot better to chemorads. Matter of fact, they're the ones that have the high success rate. If you have a non-smoker, non-drinker who has HPV negative, about 10 to 12% of the head and neck cancers that we see fall into that category. You don't have a very good outcome. Your outcome drops down to about 25 to 30% from an 80 to 90% type. There's many different types of HPV, and one of the subtypes, 16, which is very common, is fairly protective actually, in that if you have infection with it and you develop a cancer, when I radiate you, you have an 80 to 90% chance of curing that. 89% 5-year survival, I should say.
So that would be considered like a beneficial biomarker, so to speak. Like when people probably understand that when with breast cancer, you're looking for all these biomarkers to determine what the potential outcome would be. In tonsil cancer, we have something similar.
Yeah. Let's kind of come full circle and talk a little bit, wrap up about tonsils, because I think a lot of people want to know. So in general, nobody thinks about tonsils until they go wrong. It reminds me of, what was that, Emily Dickinson, pain has an element of blank. You can't remember, a time when it didn't exist, and you can't envision a future without it. So I'm paraphrasing, but when you're in it, you just want it to go away. When you're getting these multiple infections, you want it to go away, and you come in and you ask for help. As an adult, a lot of times we recommend a tonsillectomy to get rid of the chronic infection, tonsil stones, halitosis, the bad breath, things that come along with it. And when you go through that tonsillectomy, if you decide to go through it, you got to remember that it's not like a child. Children bounce back really quickly. Adolescents can behave more like a child or more like an adult. That's adolescence. And so adults, 2 weeks of pain, your doctor can put together something for you to try to get you through that better, but it's still 2 weeks of pain. And I always tell my patients, you're wearing footy pajamas and you're binge watching, streaming video. And so you're not going to be going to work and doing things. People think that they can press through it, but you're in 2 weeks of pain. There's risks of bleeding, very rarely even death. I mean, there are risks involved with this, but in general, it's a fairly safe procedure. And depending on what you read, no real outcomes that are going to hurt your immune system down the road. So you can't really tell if you were to take blood from somebody who's had a tonsillectomy, there's no real difference in the levels of antibodies that you have or your immune system and how we regulate it. And then afterwards, when you go home, you're probably going to watch out for hydration and try to take care of yourself and be in touch with your doctor and try to get through it in the best way possible.
Yeah, I think if we kind of looked at what we went through today, we know what we've learned. We've learned that there are criteria for pediatric tonsillectomy. We know that those criteria are not overly strict. In other words, there are other criteria that we can use. So we have infection, we have sleep apnea, we have loss of quality of life, loss of time at school for kids, at work for adults. We went over obstructive sleep apnea as it relates to tonsillectomy and how that might be beneficial, both in kids and in adults. We talked a little bit about, at the end here, about tonsil cancer and what the risks are, whether or not having tonsillitis in the past, whether or not that is a risk for tonsil cancer in the future, and whether or not that should play into the role of our determining whether or not we should have a tonsillectomy. I think we've pretty much covered everything you need to cover in terms of the tonsils and given people a great overview.
Awesome.
So that is our podcast episode for today on tonsils. Upcoming podcasts on tinnitus, not tinnitus, but tinnitus, that ringing you hear in your ears, vertigo. What is vertigo? What's dizziness? We'll be talking about that. And then really, really exciting, we're going to have Dutch Rojas, who is an absolute expert in the healthcare system in the United States. We're going to talk to him in a few weeks. And that's going to give us so much information on how do we navigate all of this. So until next time, thank you for watching Vital Discourse.